Hello friends, I'm Dr. Father Baker, Section Chief of Neurology at NYU Langone Medical Center. And in the next 20 to 25 minutes or so, I will provide you with an overview of spine tumors. I have no financial disclosures to make. So the goals of my talk today will be to provide you with imaging guidelines to help compartmentalize the spine tumor as to whether it is intramedullary, intradural, extramedullary, or extradural in location, and to discuss imaging features to help identify the underlying tumor. So how do you place the tumor in the correct compartment? Well, this cartoon demonstrates it well. If the cord is expanded, then it will be an intramedullary tumor. If the subarachnoid space between the cord and the extradural compartment is widened with presence of what has been described as the arachnoid cap sign, then it places the tumor in the intradural extramedullary compartment. And if the extradural compartment is effaced and replaced by the lesion, then you place the tumor in the extradural compartment. So let us start with intramedullary tumors. Case 1. 38-year-old woman with neck pain and progressive paraparesis. MRI demonstrates a heterogeneous mass expanding the cord, therefore it is an intramedullary tumor. Notice that the lesion demonstrates susceptibility along the cranial, and the caudal aspect of the lesion demonstrates enhancement, and therefore, given these imaging features, the diagnosis will be that of ependymoma, specifically cellular ependymoma, which is the most common type of intramedullary cord ependymoma, often seen in the cervical cord, is described as being multi-segmental but solitary. It's a central expansile lesion which oftentimes demonstrates hemosiderin cap and variable degrees of enhancement. Polar and tumoral cysts can be seen. DTI images, when performed, demonstrate that the tracts are splayed by this lesion and not destroyed, and this allows easy enucleation of this lesion by the surgeon. Case 2 is that of a 7-year-old boy with back pain and gait abnormality. MRI demonstrates a multi-segmental hollow cord lesion which is expansile, demonstrates multiple intratumoral and polar cysts. Heterogeneous enhancement is seen. The lesion is slightly off the midline, does not show a hemosiderin cap. Given the age of this patient, diagnosis will be that of a cord astrocytoma. Notice that this is a WHO grade 2 tumor. Most commonly, it is seen in the cervicothoracic region. Notice the genetics of this particular tumor. There is no BRAF mutation, but it is associated with a BRAF copy number gain. I already discussed the imaging features with you. Some of the differential diagnoses are otherwise listed here. What about this particular case? This is a 32-year-old man with back pain and paraparesis. Again, an expansile heterogeneous lesion is seen which demonstrates enhancement following contrast administration. Some intratumoral and polar cysts are seen. Notice that there is no hemosiderin cap. Well, no hemosiderin cap means that I would favor the diagnosis of an astrocytoma. Having said that, Notice the age of this patient. This is not a pediatric patient. This is a middle-aged patient. Diagnosis, therefore, will be that of a cord ependymoma. Again, remember this, friends. It is the age that trumps the diagnosis when you try to differentiate the two. Pediatric patient, consider cord astrocytoma. A middle-aged patient, expansile heterogeneous lesion, you favor the diagnosis of a cord ependymoma. What about this case? 22-year-old man with right arm weakness for 1 week and now right lower extremity weakness for 1 day. A heterogeneous expansile mass is seen in the cervical region. It demonstrates susceptibility, demonstrates heterogeneous enhancement. But notice the heterogeneous enhancement. It is not what we saw in the first two cases. This heterogeneous enhancement is dirty. Notice the edema associated with this lesion, not what we saw in cord astrocytoma and ependymoma. This enhancement pattern, friends, if you saw this enhancement in the intracranial compartment, top two differential diagnosis would be a metastasis or a glioblastoma. This is a young patient, no known primary, heterogeneous enhancing lesion seen within the cord, expanding the cord slightly off midline. Diagnosis will be that of cord glioblastoma, an uncommon tumor. Tractography done in this particular case demonstrates some destruction of the tracts, especially seen along the right posterolateral aspect of this lesion, which is good for the surgeon to know. Now he can use this information to plan his surgery. He or she can go in via this particular region because the tracts here are already destroyed and excise this lesion and therefore cause less iatrogenic neurological deficits if they were to occur for this particular patient. So, certain features of cord glioblastoma, they are rare, they are associated with histone mutation, enhancement pattern is dirty, heterogeneous, it is associated with a very poor survival. Next case, 31-year-old woman with left-sided neck pain and numbness. Sagittal T2, T1 and post-contrast images demonstrate a heterogeneous lesion seen in the cervical cord. There is hemosiderin cap seen, and therefore one would like to think of this lesion as in terms of a cord ependymoma. But notice no enhancement pattern, which does not favor an ependymoma. If you look at the coronal and the axial images, this lesion does not lie in the midline, it's off midline and therefore cannot be an ependymoma. Diagnosis will be that of a intramedullary spinal cord cavernous malformation that is somewhat commonly seen. This is another case with classic imaging features. You have a predominantly cystic appearing lesion seen in the cervical region with an enhancing nodule that is present along the dorsal pial surface of the cord. My question to you is, given these imaging features, this lesion is most likely associated with multiple endocrine neoplasia type 1, neurofibromatosis type 1, VHL or Cowden's syndrome. And the correct answer is Four-Hippel-Lindau disease, because the tumor here is a cord hemangioblastoma. It is the third most common intramedullary tumor. It is seen along the dorsal pial surface of the cord with a cyst with a mural enhancing nodule. As described, associated engorged pial vessels are commonly seen. Moving on to intradural extramedullary lesions. 44-year-old woman with back pain and vague lower extremity sensory symptoms. A cystic appearing lesion is seen in the dorsal thoracic region, which does not demonstrate any enhancement following contrast administration. The lesion displaces the cord ventrally, does not expand the cord, and therefore it is not an intramedullary lesion. It does not efface the extradural fat, and therefore it is not an extradural lesion. It widens the subarachnoid space both superior to and inferior to the lesion, and therefore should be placed in the intradural extramedullary compartment. When you look at this particular lesion using high-resolution T2 or CIS images, you can see a thin membrane along the superior and inferior aspect of this lesion. Cystic appearing lesion, non-enhancing, shows a thin membrane, no other lesion seen. Diagnosis will be that of an arachnoid cyst, which has to be distinguished from this particular lesion, when again there is some ventral angulation of the cord seen at the T5 level. I do not really see a membrane along the margins of this lesion. No enhancement is seen. This is a case of idiopathic cord herniation, which occurs because of herniation of the cord through its dural sleeve, seen in the mid-thoracic region. Subtle ventral angulation of the cord occurs at the involved site. Differential diagnosis would include an arachnoid cyst, which we already described, and a dorsal thoracic arachnoid web, which is characterized by the imaging appearance described as a scalpel sign. Notice the sharp angulation of that of a scalpel. Associated edema can sometimes be seen, and post-treatment, post-correction of the web, the cord gains its normal appearance and the edema disappears. Again, if one has to distinguish these three, notice if the membrane is seen, if you do a myelogram, a filling defect seen, that suggests the diagnosis of an arachnoid cyst. If there is subtle ventral angulation of the cord, no membrane seen, diagnosis will be idiopathic cord herniation, and sharp angulation seen like that of a scalpel, diagnosis will be a dorsal thoracic arachnoid web. As against that, notice that we have a cystic appearing lesion seen not along the dorsal aspect of the cord, but along the ventral aspect of the cord. It's predominantly bright on T2. It appears slightly brighter than the CSF on T1 weighted images, and on contrast axial images, no enhancement is seen. Well, one can consider the possibility of an arachnoid cyst, but then why is it slightly brighter than the CSF? It should be iso-intense to CSF. It's slightly brighter than the CSF. No enhancement seen, no other lesion seen. This lesion lies along the ventral aspect of the cord. Diagnosis will be that of a neuroenteric cyst, which is a type of an enterogenous cyst. Presence of this particular canal, which extends from the neuroectoderm to the endoderm, is described as the canal of Kowalski, and whenever it is present, it is associated with the neuroenteric cyst. Again, differential diagnosis, arachnoid cyst, but notice it is slightly brighter than the CSF on T1 weighted images, and of course does not show diffusion restriction, allowing it to be distinguished from an epidermoid cyst. What about enhancing intradural extramedullary lesions? Number one diagnosis always to consider will be nerve sheath tumors. Here seen are multiple nerve sheath tumors expanding the neural foramen. diagnosis in this particular case, multiple neurofibromas associated with NF type 1. As against that, there is an enhancing lesion seen here in the spinal canal. It displaces the cord ventrally, does not expand the cord, so it's not intramedullary in location. It does not efface the extradural fat, and therefore it's not extradural in origin. It displaces the cord. It causes the subarachnoid cap sign, demonstrates enhancement, therefore it lies within the intradural extramedullary compartment, and the diagnosis will be that of an meningioma. It is the second most common intradural extramedullary tumor, seen more commonly in the dorsal thoracic spine. Calcification is uncommonly seen, and of course differential diagnosis will be that of a nerve sheath tumor, lymphoma, leukemia, and metastasis. Whenever you see an enhancing lesion like seen here in and around the conus, if it is solitary, number one diagnosis that you will entertain will be that of a Myxopapillary Ependymoma. It is a low-grade ependymal neoplasm, WHO grade 1, likes to live in and around the conus and the chorda equina because it arises from the ependymal glia of the phylum Terminale. Differential diagnosis, nerve sheath tumor, meningioma, paraganglioma, metastasis, and of course hemangioma. We discussed intramedullary tumors, we discussed intradural, extramedullary tumors, and when we move on to the extradural tumors, these are largely bony in origin, but sometimes you see other tumors and you might find this to be an interesting one. 31-year-old man with back pain and paresthesias. Notice that you have sagittal T1 and stir images shown. On stir images, the extradural fat that you see should be completely effaced in a normal person. In this particular case, it is not being effaced, but I see abnormal signal being present there. Also, on my T1 weighted images, there is heterogeneous signal seen in the dorsal epidural fat. Upon contrast administration, there is enhancement seen in the fat suppressed contrast enhanced images in the dorsal extradural or epidural space. Diagnosis in this particular case, therefore, will be a spinal angiolipoma. It is a benign, uncommon clinicopathological entity. Tumor is composed of varying proportions of fat cells, therefore it's bright on T1 and demonstrates abnormal capillary, sinusoidal, or venous or arterial vascular elements, and therefore the enhancement. Once you look at the imaging features, you can easily make the diagnosis. It has certain elements to it that help us make the diagnosis. So to conclude, the first step when you see a tumor within the spinal canal, compartmentalize it. And once you compartmentalize it, then depending on the age of the patient and the morphological features of that particular lesion, you can further go into the differential diagnosis depending on the compartment. So in cases of intramedullary tumors, if the tumor is seen in the middle-aged adult population associated with a hemosiderin cap, ependymoma more likely. If the lesion is seen in the pediatric population with intratumoral polar cyst seen, some enhancement, diagnosis astrocytoma. If it's a cyst with a mural enhancing nodule along the dorsal PL surfaces of the cord, hemangioblastoma. Heterogeneous enhancement, midline, off midline, glioblastoma. If it demonstrates a edema disproportionate to the size of the lesion in the patient with a primary tumor, diagnosis will be that of metastasis. Intradural extramedullary cystic lesions which are non-enhancing, if ventral to the cord and brighten T1, consider neuroenteric cyst. If dorsal to the cord, if they show the membrane on high-resolution T2 or CIS images, consider an arachnoid cyst. If there is subtle ventral angulation, idiopathic cord herniation. If you have the scalpel sign, dorsal thoracic arachnoid web. If you have enhancing intradural extramedullary lesions, number one diagnosis, nerve sheath tumor, especially when associated with widening of the neural foramen. Other differential diagnosis to consider, meningioma and sometimes metastasis. For lesions living in and around the conus and the cauda equina, Myxopapillary Ependymoma is number one. You can consider paraganglioma if it looks vascular and shows phlovoids, hemangioma if there are other lesions seen that are vascular, and of course metastasis in the appropriate clinical setting. If the lesion is extradural with imaging features that I described earlier with fat and enhancement, consider angiolipoma, or otherwise you have certain other bony tumors that can occur in this particular location. So I hope this quick overview of spine tumors was helpful, and I thank you for your time and attention.